Hello, welcome back to Advanced Human Gross Anatomy. Today we have a pretty extensive dissection today. We're going to talk about an introduction to the pelvis. We're also going to be dissecting the anal region, and we'll be talking about the male reproductive system in some detail as well. So let's get going here and talk about a review of the bony anatomy of the pelvis. The pelvis is made up of three bones. These coxal bones here, you can see the ilium here, the pubic bone here, and the ischium behind that. Better way to see this is this. This is looking at the inside of the right pelvis. This is the ilium here on the top, the crest of the ilium here. Here's where the sacrum will attach on the inside of the right ilium. The green shaded area here is the ischium, and the pubic bone is in red. So these are on each side. They articulate posteriorly with the sacrum. You can see here is a nice shot of the SI joints, the sacroiliac joints, here and here. The bottom of the sacrum is the coccyx, which is down here. The lumbar spine sits on the top of the sacrum, the bottom of the sacrum being the coccyx down here. We'll talk more about that in a little bit. And they articulate with each other in the front, anteriorly, at the pubic symphysis. My favorite name for these three bones is the innominate bone. That name literally means without name. It's innominate, but they named it that, so I think that's funny. The differences here you can see between a male and a female pelvis, the female being on the left side here, the male obviously being on the right. The most notable difference is that the true pelvis on the female is much larger. Look at the pelvic inlet, or the outlet here, the true pelvis compared to the male, much larger. And that's because it has to accommodate the birth of a child. You can see, if I show you a different picture here, contrasting these two bony structures, can you tell which one is the female and which one is the male, side by side? Obviously, this is the female here. We'll look at the pelvic bones, their orientation to each other here compared to the male. Female is going to have wider hips. Hips is a funny way to say this. I don't know why people call this their hips. If Simon says put your hands on your hips, everybody puts their hands up here. I'm not sure why. The hip is a joint. If you were to put your hands on your hips, that would probably be pretty painful. It requires some dissection to get down to the joint here. But anyway, in the vernacular, we call this the hips. The females have a little bit wider hips on the sides here. Lower center of gravity. Estrogen and progesterone kind of help cause the change in the shape of the female pelvis as it prepares for potential childbirth. The male testosterone on the other side with the male will cause a larger muscle mass in the chest and the shoulders, giving it the male a higher center of gravity, but the pelvis just doesn't have the opening into the true pelvis as the female does. You can see here a lateral view of the right innominate bone, or right pelvic bone, right coxal bone. Here you can see on the lateral side is a deepening called the acetabulum. This accommodates the head of the femur to make up the hip joint. So when we're actually talking about the hip, this is what we're talking about, where the femur attaches or articulates with the pelvis. You can see here, it's interesting that the acetabulum is actually made up of all three coxal bones. It's got the ilium on the top portion here, the ischium on the posterior and inferior portion, and the pubic bone on the anterior and inferior portions. So the acetabulum is what the femur articulates with. The sacrum at the bottom of the lumbar spine, which would be sitting here, this was originally 5 sacral vertebrae in utero, and even shortly after birth, these were 5 individual vertebrae that fused eventually into this triangular shaped bone at the bottom of the at the bottom of the spine that's fused shortly after birth. It is anchored between those two innominate bones, those two coxal bones on the left and the right. Again, if we show this here, we'll show this one here. You can see the sacrum on the bottom of the lumbar spine and the right coxal bone here and the left coxal bone. I think it's easier to see it from the front, how it attaches. They articulate here as the SI joint on the right and the left. So you can see that. If we go back to here, I want you to be able to pay attention to a few of the structures on the sacrum. The sacral foramina are these holes coming out of the sacrum on the anterior side, and then you've got dorsal sacral foramina, two posterior sacral foramina here as well. So anterior and posterior views. This is where on the anterior side, this is where the ventral rami from the sacral portion of the cord are exiting to form the sacral plexus on the right and the left here. On the back side, the posterior sacral foramina, smaller branches called the dorsal rami, are coming out those holes. They provide sensation and some motor innervation to the posterior trunk, particularly in this area of the multifidus musculature. The coccyx on the bottom, you can see here, 3 to 5 fused vertebrae again, 4 fused vertebrae most of the time. There is one nerve that exits the first coxal vertebrae here, but it's fairly insignificant. It provides a little bit of sensation near the anal region is all, so we won't worry about that. Some people feel like this is a vestigial organ or an unnecessary organ. I've worked with patients in the clinic who have trauma to this area, usually a blunt trauma, a fall from a height, landing on the tailbone, causing tremendous pain into the SI region of the low back, shooting down the legs into the glutes. And I've even heard of sometimes it being taken out, removed. Sometimes surgeons will say that it's a vestigial organ. You don't really need that organ. However, I believe that this provides a really important attachment site for musculature of the pelvic diaphragm, which we'll talk about in a little bit. So later on, when we're talking about the musculature of the pelvic diaphragm and its attachment sites, I'll let you tell me what you think about if this bone is really unnecessary or not. If we look back here at the pelvis itself, you can see there's a pelvic inlet, which is, if you look at this like a funnel, it funnels down from the sides here, from the top of the pelvis coming down. This would be the pelvic inlet coming down. There's a ridge here called the pelvic brim, which is this bony ridge that comes around this way. That's an important landmark as well, because that's going to be the separation between the false pelvis, which is coming up this way, and the true pelvis, which goes down and becomes the birth canal, where a baby would exit. You can see there. So the difference between the true and the false pelvis. If we go back to the sacrum here, the sacral promontory, this is the most anterior portion of the sacrum. In standing, when you're anatomically, erect vertically, it acts more like a roof to the pelvis. Many people think this is like the back side of the pelvis. It's really, if you look at this picture again here, it really tips backwards, the sacrum does. And so the lumbar spine, as its curvature comes down, as that lordosis comes onto the first sacral vertebrae, you can see how it tips it's almost like the roof of the pelvis as the sacrum tips there. So the sacral promontory is just this most anterior portion of the sacrum. Let's go back to this picture and talk about the pubic symphysis. This is where the two coxal bones, or the two innominate bones, attach anteriorly, where they come together and meet. It's separated by a piece of fibrocartilage, a disc here, a fibrocartilage disc. It's actually a joint, an amphiarthrosis, a joint that allows a slight amount of movement for walking, running, exercise of sorts. Also, certainly with childbirth, that's going to allow a certain amount of movement to allow the pelvis to open. You'll see a big hole here called the obturator foramen. And you think of that hole, it looks like it's a big hole on each side here. It's just kind of between the ischium here and the pubic bone on top on each side. Nothing large passes through there. It's not insignificant, but it's not large. It looks like there would be something big going through there, but it's really just the obturator nerve, artery, and vein that come down and help innervate the adductors of the thigh on the medial compartment of the thigh. In between the pubic bones here, right below the pubic symphysis, is this pubic arch. You can see how the inferior pubic rami come up and then they join each other here, but that kind of creates this arch, this pubic arch. The ischial tuberosity, which is this bottom portion of the ischium below the obturator foramen, it's where you should be sitting, unless you're slouching and sitting on your sacrum in the distal part of your the coccyx in the distal part of your sacrum. That's really where you should be sitting, putting most of your weight through the ischial tuberosities, this thicker portion of the ischium. You can see on this picture too the ischial spine, which is this bump right here that comes off of the ischium. If we go back to this picture, maybe you can see it differently too. So this is the lateral view of the right pelvis again, but you can see the ischial spine. So above that is still ischium and below that is still ischium. Here you can see the greater sciatic notch right up on top, and then the lesser sciatic notch. So the ischial spine is what separates those two notches. Now they're notches without any ligamentous structure there, but when you add the ligaments to it, what happens is they become foramina. So they become holes here. So the greater sciatic foramen and the lesser sciatic foramen right here. So there's two important ligaments that make that those notches into compartments, holes where things can travel through. The sacrotuberous ligament, so from the sacrum, coming down, a broad attachment from the sacrum coming down to the ischial tuberosity here, and the sacrospinous ligament from the sacrum here coming down towards the ischial spine. So those, when they create the greater sciatic foramen, which is going to be the exit point of a few important structures. The sciatic nerve is a big one that exits this greater sciatic foramen. The piriformis muscle, also the internal pudendal artery and vein, as well as the pudendal nerve will exit this. The pudendal nerve and the internal pudendal artery and vein will exit the greater sciatic foramen. They'll go around the ischial spine, and then they'll come right back into the lesser sciatic foramen and do some work. We'll be looking at that in a little bit as well. The SI joint we've talked about a little bit here, where the sacrum meets the ilium on each side. A common site for pain in this area, these dorsal SI ligaments. There's an area here called Fortin's area, F-O-R-T-I-N, Fortin's area. That's often a diagnostic indicator if people have issues with their SI joint. Let's now talk about the pelvic diaphragm. The pelvic diaphragm really supports the pelvic viscera. So as we talked about before with the coccyx, this is going to come important here, this extra bony support of that coccyx really helps support the musculature in humans, animals that walk upright. This is going to be a very important structure. Here you can see it from the right side, looking from the inside out. We're looking inside the pelvis towards the outside of the inside of the right pelvic bones here. You can see the sacrum here. Look how it makes that roof of the pelvis. But it almost looks like a hammock here, this pelvic diaphragm. I mean, imagine it coming towards you on the other side. We'll show another picture of this in a second. But it kind of slings down back on each side like a hammock coming down. It has attachment sites at the pelvic brim. You can see here's that pelvic brim, near the pelvic brim. And creates this hammock at the bottom part of that true pelvis underneath here. Has openings. You can see here, this is obviously a female. You can see openings for the rectum, openings for the vagina and the urethra. The male would be the same, except obviously without the vagina. Let's look at a different view of that here. here's that same kind of shot. This is now the body would be supine, to be lying down on its back. So you can see the pelvic brim here. Again, the rectum, the vaginal opening, and the urethra. Here you can see the rectum, the opening for the vagina, and the rectum, or the urethra. Rectum, vagina, urethra. Anterior here will be the pubic symphysis. You can see the coccyx at the back here. Sacrum would be what we're looking at on the top. Now, there's a few important muscles here. A couple of them we'll go over right away, called the puborectalis. So the names of these are not very clever. They give you a lot of clues as to where they are and what they do based on their naming. So the puborectalis is going to come from the pubic bone, come around and sling around the rectum here. It's going to come straight up to the other side of the pubic bone. So it kind of hooks around the rectum, the puborectalis. Now, just lateral to that is the pubococcygeus. So you can see the pubic from the pubic bone, pubic ramus coming down, attaching to the coccyx on each side, the pubococcygeus and the puborectalis here. Now, just lateral to that, you'll see the iliococcygeus coming from the ilium down to the coccyx, the iliococcygeus on the right and the left. And those three muscles together, puborectalis, pubococcygeus, and iliococcygeus here, those three on each side make up what's called the levator ani. Now that word actually makes a little more sense when we're talking about the puborectalis. A lot of people leave out the puborectalis when they name this. They just name it as the pubococcygeus and the iliococcygeus. But I think the puborectalis is important to describe here because of what it does. It slings around the rectum. Now imagine what that does when it contracts. When that muscle contracts, it's going to almost kink the rectum here. It's going to help kind of elevate the rectum. So those three muscles called the levator ani, to elevate the anus. That's an important function here. And then the fourth muscle here of the pelvic diaphragm is the ischiococcygis, which is here coming down on each side from the ischium to the coccyx bone again as well. Here you can see the piriformis exiting as well through the greater sciatic notch, which we'll come to in a little bit. But those four muscles, puborectalis, pubococcygeus, iliococcygeus, and ischiococcygis. You can see how they all attach to the coccyx. Now, if you take that out, boy, what a tough thing to do to the musculature that helps support the pelvic viscera, all the organs of the pelvis. So I'll let you make your own decision, but I'm not a surgeon. I'm not advising anybody in this area, but I just think that's interesting when people want to take that out. Here you can see the male, obviously without the vaginal opening here, the urethral opening, and the rectum here, the anal opening. Here's the puborectalis. Here's pubococcygeus on each side, iliococcygeus, and ischiococcygis. And again, piriformis leaving. We'll talk about that in a little bit as well. Okay, we talked a bit about the perineum in the last dissection, or maybe the one before that, I'm not sure. But the area between the legs, and we described this as kind of a diamond-shaped area with the boundaries of the pubic symphysis on the anterior side, the ischial tuberosities laterally, and the coccyx posteriorly. That is the perineum. If you're involved in any nursing care facilities, you may be charged with pericare, which is just the nursing care helping of patients care for this area who are maybe unable to do it on their own. But again, that diamond-shaped area, the anterior portion here between the two ischial tuberosities and the pubic symphysis would be that anterior portion of the called the urogenital triangle. This makes a little more sense. I'm showing a male here. Makes a little more sense if I showed a female. Imagine the ischial spines here, spine of the ischium, the pubic symphysis, and the coccyx coming down here. You can see if I draw a line straight through here, between the ischial tuberosities, that would be the urogenital diaphragm, or the urogenital triangle from the urethra and the vagina, the vaginal opening here. The male doesn't have the vaginal opening, obviously, but it also doesn't have the urethral opening here either, which you go, why is that the urogenital triangle? This is actually the area where the urethra will come out of come down out of the bladder. It goes through the pelvic, through the musculature here, the pelvic diaphragm, and then it makes about a 90-degree angle right above the scrotum as it leaves through the bulb of the penis into the corpus spongiosum, which we'll learn in a little bit. But that's right where it leaves that area. So it's still considered the urogenital triangle. And then the anal triangle, or the anal rectal triangle on the backside from the ischial tuberosity to the coccyx, where the anus is, the end of the rectum. Okay. Now, in this dissection, what I'd like to do, we're going to flip the cadaver onto their stomach. They're going to be prone, and we're going to try to take the skin off to expose musculature of the gluteal region and the upper thigh. So, what I'd like you to do is use a scalpel and cut right down the center of these areas, right down kind of through that proximal thigh. And then remove the skin on each side of that cut, kind of flapping it. You can make a cut superiorly and inferiorly, opening that to each side. And this will eventually reveal the glutes, the gluteus maximus here, and the gluteus minimus, or I'm sorry, the medius right up on top here. So you can see it will reveal that. Now, in my experience with this, there's also a lot of adipose here. These bodies have been lying flat for a bit. They may be kind of misshapen a little bit back here on the tissues, and it may take a bit to crisp it up and make it look all beautiful like this picture, but do your best to try to clean that up and get to the point where you can look at the gluteus maximus, the fiber orientations here coming diagonally. Eventually you're going to take a gloved hand and slide it under the gluteus maximus from the bottom and under the gluteus maximus from the top, trying to really separate it from the underlying musculature. And when you do that, you're eventually going to cut it from its origin here on the ilium and the sacrum. It has a very broad origin. This won't be easy to do. It's got an extensive origin here. You're going to cut it off of its origin once you separate it from the underlying structures, because I don't want you to dissect down and cut deeper. And I want you to preserve some of these deeper musculature. Try to not disrupt that underlying tissue. But you're going to cut it off of its origin, the gluteus maximus, and reflect it laterally, kind of like this picture here where it's shown where it's going to reflect laterally to the side. So we can expose some of that underlying musculature. Now, you're also going to see the gluteus medius, which you should be able to see on the top portion of that gluteus maximus here. You can see it nicely here. A portion of the gluteus medius in Netter's drawing has been removed. So it's not just cut off, it's been totally removed to see what's underneath that, which is the gluteus minimus, which is this muscle here. So gluteus medius is here and here, in between, kind of underneath that. It looks like it's in between in this picture, but this is just part of that's been removed. The gluteus minimus and the gluteus maximus coming on top. The gluteus medius and minimus actually come down off the iliac crest, a broad insertion off the iliac crest. They come down to the anterior, they kind of come in front of the surgical neck of the femur and attach to the anterior aspect of the greater trochanter. So these two muscles together are medial or internal rotators of the femur. The gluteus maximus, which you reflected off here, attaches to the posterior aspect of the greater trochanter. So it will be more of a lateral or external rotator of the femur. Now, the piriformis, which is this muscle right here, deep, kind of inferior a bit to the gluteus minimus and medius, this is a bit of a landmark. We've seen it already as it comes out of the greater sciatic foramen, but it comes actually from the anterior aspect of the sacrum, goes out that greater sciatic foramen, and attaches again to that more posterior aspect of the greater trochanter. So along with the gluteus maximus, it will be a lateral or external rotator. You can see the sciatic nerve barely here. It's been cut, so you can't see it. Let's find a better shot of that here. Again, piriformis, Gluteus medius was cut, so you can see underneath it, which is the gluteus minimus. Here's the gluteus maximus attachment to the sacrum and the ilium, and then where it would attach here. But the sciatic nerve, which is a huge nerve, you'll be surprised how big this nerve is. It's about the size of your finger. It's a big nerve coming from L4, L5, S1, 2, 3, 5 levels of spine make up spinal rami make up that massive nerve. It comes underneath the piriformis, which you can see here, and goes down to the back side of the thigh. Supplies most of the posterior thigh, and then the anterior, posterior, lateral compartments of the leg, and into the foot as well. You can see just next to that piriformis, on either side of, just above the piriformis. We'll talk about this one first. This is called the superior gluteal artery and nerve. You can see that nerve here. That is going to come above the piriformis. It's supplying the gluteus medius and the gluteus minimus with innervation. And then you've got the one below that, the inferior gluteal artery and nerve here, supplying the gluteus maximus. So again, piriformis being a bit of a landmark to be able to see those areas. Okay, all right, let's keep moving on here. Now we're going to talk about the ischial-rectal fossa. Now this is an interesting area. It's right to the lateral sides of the rectum and the anus here, and it's to the boundaries of the ischial tuberosity here, the ischial ramus, the ramus of the ischium on either side. So here's this kind of triangular shaped area on either side, this ischial-rectal fossa. So you got the rectum coming down, the pelvic diaphragm, which we've talked about here and here on each side, and the ischium, which we've seen on each side here. What else here? And then in between that, it's just a bunch of adipose, fatty tissue here. This ischial-rectal fossa is mostly just made up of adipose tissue. Becomes important because of what's inside of it here. So there's this pudendal canal, which is sometimes in some textbooks called Alcock's canal, but the pudendal canal is right here. It contains three really important structures: the pudendal nerve and the internal pudendal artery and vein on each side. Right here and right here. That is kind of adhered to the muscle called the obturator internus, which covers the internal opening of the obturator foramen. Remember the foramen being that big hole. This is the obturator internus is musculature that covers the inside of that, and the pudendal canal is adhered to the inside of that. Now, this area is unique. It's important because it used to be used a lot during childbirth to anesthetize the region around the vagina, which often has tearing in it or around it. And so what a doctor would do is palpate. An obstetrician would come in and palpate into Alcock's canal. They would find that ischial-rectal fossa and then push into that adipose and then find the spine of the ischium here, or the ramus of the ischium. And then they would inject anesthesia into that area, which would numb up that pudendal nerve and then cause the area around the vagina to be more numb in the perineum there. Now, this is not done very often anymore. Typically, women will elect for a spinal block now instead of the pudendal block. But this is still done, I'm told, in some parts, and typically by older physicians, maybe typically in rural areas, but the perineum, the pudendal block right here in Alcock's canal. Now, another just interesting thing about this Alcock's canal or pudendal canal is that I'm an avid cyclist, and sometimes if people are brave enough, they'll come up to me in the clinic, or just friends will say, "Ooh, I'm losing sensation in the area between my legs." They don't know what to call that, the perineum usually, but the area between my legs, it'll either be painful or it'll go numb. And they'll wonder what's going on with this. Long bike rides, what will happen is the saddle of this bike seat will push up into this area and press into this ischial-rectal fossa and compress the pudendal canal here, putting pressure on that pudendal nerve. and that's going to cause irritation wherever that goes into the perineum. So there are several solutions for this. I mean, the easiest way is just get a different saddle. There's different shapes and types of saddles that can help with that, but usually pain and numbness into the penis or the scrotum in the male, or the clitoris or the labia in the female will be kind of an indicator that on long bike rides that you're getting pressure into the pudendal canal here. Now you can see the pudendal artery. Let's see. We find a different area. So remember we talked about the pudendal, the internal pudendal artery, which is actually a branch off the internal iliac artery, but it comes off and it exits that greater sciatic foramen, and then along. Let's see. Sorry, I kind of lost my place here in my notes. And then along with the pudendal nerve and the internal pudendal artery and vein, they will come over that ischial spine and then re-enter right back into that lesser sciatic foramen. And that's where it's going to be coming into that pudendal canal, where it comes into there. So that's what you'll see there. Now, what you'll want to do with your cadavers in this dissection is block them up. Place some blocks. I've got some blocks for you in the lab. Put a couple of blocks underneath the pelvis of the cadaver to help lift up the anal region. And what I'd like you to do is dissect one side of this a little bit farther to expose some of the branches of this pudendal artery and nerve, the pudendal nerve and internal pudendal artery as they go towards the anus. Here you can see as they're exiting that pudendal canal, the pudendal nerve coming up here, and it's going to shoot branches off called the inferior rectal branches of the pudendal nerve, which are going to go towards the anus. You can see here coming off the pudendal nerve coming toward the anus. The internal pudendal artery right here along with it from that pudendal canal as well will send off branches called the inferior rectal or inferior hemorrhoidal. Sometimes they're called branches coming off again towards the rectum. You'll also have some transverse fibers too. Let's see. Here you can see just the inferior rectal or inferior hemorrhoidal branches of the pudendal nerve coming toward the anal region. Here you can see some of the muscular. Let's see. Yeah. Well, sorry. Find a better shot of this. Here you can see some of that internal pudendal artery. This will also send branches off, transverse perineal branches coming up towards the anterior genital region up on top here. So you can see some of those. We'll go to a different view here. The sphincter ani externus, following down on the terms sheet here, is a circular arrangement of muscles around the anus, around the anal canal. Its main function, the sphincter ani externus, its main function is to stop a bowel movement from exiting the body until you can find a more appropriate place to do that. Along with the puborectalis, remember from the levator ani, elevating the anus, kind of crimping off that the rectum, and then the external sphincter ani externus, or the external anal sphincter here, also helping with that. Now what I'd like you to do from here is turn the cadaver back over, so it's going to be supine, face up, and this time you're going to block up the pelvis. You're going to take those blocks out and then put them back underneath the pelvis, but more in a kind of in the low back, above the crest of the pelvis, above the crest of the ilium. Now, this is a part of the dissection. There's a few times in this lab process here in the dissections that we're going to do. There's a few times that are going to be a little more difficult to do, a little more challenging. This is one of those times. We're going to have to do a little self-talk before we get into lab today. This is going to be one where we take the one of the limbs off of the body. We're going to actually saw one of the legs off of the body. So that's hard to do. It's not just physically, but mentally. You kind of got to get your head around that one a little bit before we start working here. So before we remove one of the legs from the cadaver, we're going to use a scalpel to chart a midline through the pelvis, kind of a guide of where we're going to be cutting. Okay, and in the male, you can take the penis and just use the scalpel and bisect it mid-sagittally, just right down the middle. And then you're going to use a saw to eventually cut through the pubic symphysis, right down the middle. Right down the middle. If in the male, it would be the prostate. In the female, you're going to go through the vagina and then the uterus. And then the rectum. Now, when you cut through the rectum, you'll likely reveal some material, as you saw through that. Remember that anything within the rectum, any material there will have been bacteria-free. It doesn't have any bacteria. It's been fixed with chemicals and been sitting there for some time. But what you can do is first take some string and tie off proximally to the cut where you cut, probably more toward the sigmoid colon. Take some string and tie that off, cinch it off nice and tight, so that no more material from the large intestine comes out. So hopefully that can be easy. And just clean it up, and so we'll be sure to have that there. Now you can decide which limb you'd like to take off a bit. I would encourage you to take off the right limb, and I'll talk about that in a second, but you can look at your dissection and decide which is the best posterior abdominal dissection, which side has the better posterior abdominal dissection. But I'm going to suggest that we take the right limb off, just because it's going to be a little bit easier to not sacrifice the large intestine. It's difficult, too, when you go out the left side to not cut the inferior mesenteric artery, and I know we've spent some time preserving that, so I don't want to cut that off. But what you can do is basically just move the ilium, the cecum, the ascending colon, just move all of that material, that intestinal material, push it over towards the left of the midline. And then the only major casualties you'd have on the right side by cutting through the right would be the right gonadal artery and vein, and the right ureter. So that's kind of all you'd have there. So to do this, though, to cut through that, you probably have to have a lab partner taking one lower extremity on each side and pulling it apart, kind of separating that tissue so that another lab partner can come down with a hacksaw and saw down. Now, again, this is a difficult lab to do. It's hard to take somebody's limb off. So just be mindful of that, and we'll talk about it too when we get there. So as you cut through the sacrum, I want you to cut all the way up. So coming from the in between the legs, again from the through the penis or the vagina in the female, through the prostate in the male, the uterus in the female, through the bladder, through the pubic symphysis, bladder, rectum. You're going all the way up. You keep cutting. You're going to cut up until you go through the sacrum until about the fifth lumbar vertebrae. Now you know where that is because if you take the hands, the top of the pelvis, and go straight towards midline, you're kind of right between the fourth and fifth spinous processes, roughly. That's kind of where you are. So one way to do this would be to cut up from the bottom through the sacrum, and then cut from the lateral side just above the pelvic crest until you meet that mid-sagittal cut that you came up from initially, and that will complete the removal of the limb. So then you'll have one limb that you can take off. Now the benefit of this, if I skip to a different picture here, the benefit of this is that you're going to get this view, which is really helpful to see, versus trying to find some of these structures from top to bottom or from front to back. As you're kind of looking in, you'll be able to look at the pelvis from a sagittal view, which is going to really be a large advantage to find some of these important structures that we're going to find. Okay, let's keep moving on here. If I look at, let's look at this picture here. Now, for the remainder of this lecture, we're going to be focusing on the organs of the male reproductive system. So those of you with female cadavers, you can take some time and start and just clean up some of the previous dissections that we've done. That'd be a good use of your time. But also, I don't want you to forget that all of you will need to be responsible for the material on the gender of the cadaver opposite of what you're working on. So if you have a male cadaver, we're going to keep going and be dissecting more into that today. If you have a female cadaver, you're still going to be responsible for the information on the male cadaver, and vice versa when we get to the female. So don't simply study the gender that you're working on. Take time and review with your lab partners on other tables what's going on. Now, what you can see here in the perineum, there's this central tendon of the perineum, this central tendon. This is, or the perineal body is sometimes called the perineal body. It's a muscle attachment site. You'll see the bulbospongiosus muscle. Bulbospongiosus right here in the midline, coming down. It's more anteriorly. The external anal sphincter, you'll see here again on the side. You'll see some transverse, some superficial and deep transverse perineal muscles. And then you'll also see this ischiocavernosus muscle on each side. Okay, in the male, that's going to go toward the base of the penis on each side, and the bulbospongiosus is going to also go towards that. Now, this is called the crua, which literally means cross. It's the same root for crucifix. Apparently, when the Greeks looked at this, where the ischiocavernosus comes on each side and the bulbospongiosus comes up, they thought that looked like a cross. So the crua is just where they meet in the anterior part here. Both are going into the erectile tissue of the penis, which we'll talk about in a little bit. The ischiocavernosus on each side going into the corpora cavernosa, plural, on each side, or the corpus cavernosum, and the bulbospongiosus going into the corpus spongiosum in the penis. We'll see that in a little bit as well. And this is, again, where the urethra, right in this area here, is where the urethra is going to make that 90-degree turn and travel into the penis at the bulb of the penis right here. Now, if we look at the female, just briefly here again you can see the external anal sphincter, the superficial, and there's a deep underneath this transverse perineal musculature. The bulbospongiosus spongiosus here kind of surrounds the vagina, likely for grasping the male penis during intercourse, also covering some erectile tissue. It also has some ischiocavernosum muscles here going up toward the pubic symphysis and the anterior portion of the vulva at the clitoris. So you can see here. So similar orientation between the male and the female. If we talk now, switch to our the urogenital diaphragm. Now, this is an interesting area. This is obviously the male here. There's no female. There's no vaginal opening here. But this is a fascial sheath. The urogenital diaphragm is a fascial sheath, superficial, so toward the surface of the skin compared to the pelvic diaphragm. Pelvic diaphragm would be deep to the urogenital diaphragm. But this fascial sheath is actually two layers that span between the parts of the ischium. You can see it here on the inside. So the ischial, the ramus of the ischium here, and it spans between there on either side. So the ischium on both sides. In the male, it's going to have the exit of the urethra. In the female, it will also have the exit of the vagina here as well. So in that, this is more of the urogenital triangle. Remember, here's the ischial tuberosity. So remember that triangle coming up here. That's that. So between these two layers of fascia and the urogenital diaphragm are deep transverse perineal muscles. You can see underneath here would be these deep transverse perineal muscles. So that superficial layer has been dissected off. You can see now that transverse perineal musculature there surrounds the urethra on that side. So that's going to give you the ability to stop the flow of urine. So the external urethral sphincter is right here as it surrounds the urethra, or sphincter urethrae musculature, right there. Okay. If we look now at the well, here's a better shot of this from a kind of a coronal view. You can see that external urethral sphincter right here as it comes around, closing off within that urogenital diaphragm the exit of the urethra. Here's a different shot of that as well. The urogenital diaphragm right here. The external urethral sphincter would be right there, closing off the urethra. Let's see. Now, if we talk about the penis in the male, the penis is actually made up of three compartments made up of erectile tissue. The erectile tissue here, there's two dorsolateral masses. And this always confused me for the longest time. I'm a little embarrassed to say it out loud, but it embarrassed me because dorsolateral. But you're seeing here, it's on the ventral side. In my mind, when I'm talking about the anatomy of the penis, I'm not assuming that it's in an erect position, but that's how it's named. So imagine the penis becoming erect. These dorsolateral masses are actually going to be on the dorsal side. Anyway, if that's not confusing, I'm trying to make that not confusing for you by saying that. But these dorsolateral masses provide the rigidity of the penis to cause an erection. So the corpus cavernosa, cavernosum here, singular, or the corpora cavernosa, plural on each side, these two masses, which we'll see a cross-section in just a little bit here. They're cavernous, the corpus cavernosum. They're cavernous because they're sinuses that enlarge with blood during an erection. There's one ventral medial mass, which is right here, this ventral medial compartment, which is also expands at the end. You can see how it expands at the end here at the glands of the penis. It's basically the same structure, just a different shape is all at its distal end. The corpus spongiosum is right here. So the corpus spongiosum is that ventral medial mass. But again, ventral, because in an erect position it would be towards the front. It also enlarges during an erection, but doesn't get hard like the dorsolateral masses, the corpus cavernosum, because it can't get hard, because it can't get too firm, because it contains the urethra. So we call this urethra, as it goes through the corpus spongiosum, the spongy urethra. And it can't get hard because that's the exit for semen to come through. So it can't pinch that off. So the urethra has a couple different parts here. The spongy urethra we've talked about already, going through the penis, exiting the body. The membranous urethra is where it goes through the urogenital diaphragm. And the prostatic urethra is where it goes through the prostate gland, right here. The prostate gland is an interesting area here because as the male ages, the prostate typically enlarges. The trouble with that is that as it enlarges, a couple things can happen. It can constrict the prostatic urethra as the urethra exits through the prostate gland, and that will cause a decrease in flow of urine. It can also enlarge and put pressure on the internal and external urethral sphincters here, causing them to not function properly, and then you might get some leakage. So a couple of things can happen with the prostate gland. Decreased flow of urine as it pinches the prostatic portion of the urethra, and as it pushes on the internal and external urethral sphincters, can cause some leakage. There is some treatments for this, some radiation, laser treatments. Some people will still get their prostate removed. I think they're trying to get away from that more and more as time goes on. Let's see, the bulb of the penis, here's where that 90-degree angle happens. That's why in that urogenital triangle, you can see how it comes down and it just turns into the bulb of the penis here, the proximal portion. The distal portion of the penis, called the glans here, which would have a foreskin or a prepuce that comes off of it here. And then you can see how it kind of makes this ridge here. It would create a ridge there. That's called the corona. The corona is this widening area of the distal end of the penis, likely for better stimulation of the female during intercourse. But it's not really a difference with the spongy urethra and its function. It's just it changes its shape a bit there. I think that's what I wanted to see there. Let's talk about the suspensory ligaments here. Suspensory ligament is this portion here from the anterior abdominal wall coming down to the penis on the top portion. It helps hold it in place, helps keep it on kind of attached to the abdominal wall. I've read of some procedures, like when we're talking about augmentation procedures of breast tissue in females. There's also I've heard about some procedures in the male for enhancement of the penis. One would be to cut this suspensory ligament and then allow the flaccid penis to hang a bit lower off the abdominal cavity. It doesn't change the size of an erect penis, but it might make it hang a little lower in a flaccid state or non-erect state. You can also, if males wanted to increase the size of the penis, I've heard of procedures where they can take fat from other parts of the body and put it into the area to enhance into the penis to enhance the size of the penis. I think that's pretty rare, but I've heard of those things. The bulbourethral gland right here, you can see kind of on either side of the, within the urogenital diaphragm on either side of the membranous urethra. So we're looking just at one side, but it would be on the other as well. This is difficult to find. It's about the size of a pea, so don't search terribly hard to find it, but it secretes a mucus that coats the spongy urethra. Remember, the spongy urethra is the exit site of semen, but also urine. And so the urine is more acidic as it leaves the spongy urethra exiting the body. And so you kind of have a natural acidic environment in there. So before ejaculation, as the male gets sexually excited, this bulbourethral gland will start to secrete this mucus material that will help kind of neutralize that acidic environment within the spongy urethra, so that cells that are traveling through that area can actually survive. A cross section here. Let's see. I put this picture in there too, but I think we've covered what we need to here. Cross section of the penis. If you look at this from kind of straight on, you'll see a couple of a superficial and a deep dorsal vein on each side. You'll see a pair of dorsal arteries on each side of that, and then the nerves coming off of there as well. On the dorsum of the penis, you'll also see these deep arteries in the corpus cavernosum of the corpora cavernosa, if it's plural, of the penis. And this is what actually engorges with. This is what you're getting the blood flow to those cavernous areas to actually cause the tissue to become erect. After an erection is over, the smooth muscle around the deep arteries here will constrict, and the venous drainage will bring that blood away from the penis. The venous drainage will dilate, and blood will drain from the penis, causing the penis to become more flaccid again. This is why in those commercials, when they say, if you're experiencing an erection that lasts more than 4 hours, go to the emergency room. I would think so. That would be, first of all, just really uncomfortable for a long period of time, but also what you're doing is you're constricting the venous return, which is causing the blood to stay in the penis, which doesn't help the fluid, the nutrition to circulate, and then you could actually get some tissue death, some necrosis in the area as well, which that's something you probably want to avoid. Let's see. Now, just a couple more slides here as we review some general things about the pelvis. Remember the sympathetic trunk? You'll still kind of see some of this coming down here, even though that all those preganglionics are coming from the thoracolumbar area, from the sympathetic trunk. They do extend down to the coccyx. You can see here as on each side, there's a portion here called the ganglion impar, which is where the two sides of the sympathetic trunk meet, kind of right in front of the sacrum. Remember that the sympathetic portions here are going to have, we talked about splanchnics, the thoracic splanchnics, which come down and there's ganglia kind of in front of the aorta. There's sympathetic trunk fibers in the lumbar spine also that give off their own branches called the pelvic splanchnics. These are coming from, I'm sorry, the sympathetic trunk from the lumbar spine, giving its own gray rami to form the lumbar splanchnics. That's what I meant to say here, coming off the lumbar spine. But again, those are mostly sympathetic. The thoracic splanchnics and the lumbar splanchnics are mostly sympathetic fibers coming off of those gray rami of the sympathetic trunk. But down in the sacral portion, if you'll remember that the cranial sacral portions of the spine the cord give off parasympathetic fibers. So these splanchnics coming off of the sacral region are going to be pelvic, going to the pelvic organs are going to be primarily from the sacral spinal nerves, parasympathetic fibers. Those are the pelvic splanchnics. So you've got thoracic splanchnics above the diaphragm here, lumbar splanchnics from the sympathetic trunk in the lumbar region, and then the pelvic splanchnics are going to the pelvic viscera. There will be some gray rami coming off of the sympathetic trunk here, but in this area, mostly what you're going to be looking at are these pelvic splanchnics, the parasympathetic fibers. Let's see here. This is an interesting view of the abdominal aorta. You can see the vertebrae here, the left side of the sacrum. You can see the aorta coming down into as it bifurcates into the external iliac artery and the internal iliac artery on the right side here. You can also see, if I go back to, I think you can see it better on this, the obturator nerve coming down from the lumbar plexus, medial to the psoas musculature, medial to the psoas major. Exits through that obturator foramen, like we talked about, along with that internal obturator artery and vein, which come down and supply the adductors of the medial thigh. The internal obturator artery does supply some of the most proximal portion of the medial thigh. Most of the medial thigh, from a vasculature perspective, is supplied by the deep femoral artery, but that comes down through there. And then I talked about the internal iliac, the common iliac arteries here as it bifurcates off the aorta, the common iliac veins, and then the internal iliac arteries and the external iliac arteries and veins on each side. You can see that. And then the ureters, another thing you'll see from the kidneys coming down. Remember that these are retroperitoneal. They're not immediately obvious to find, the ureters, as they come down retroperitoneally here, but they're going to come over the psoas. Are going to come over kind of right where the bifurcation of the common iliac happens into the external and internal iliac. And they come down crossing into the lateral side of the upper portion of the bladder. So you'll be able to kind of see where that enters there. Okay, boy, that was seemed like a lot. Thank you for your time, and I hope you learned something. I hope that was clear. I look forward to seeing you in lab, and we'll talk then.